This lecture is about diagnostic accuracy studies. The obvious question to ask when presented with a new test is how accurate is it? Accuracy is defined as the proportion of times that the test is correct, but unless it's 100% accurate, it doesn't give you all the information you need. For example, take two tests that are both 90% accurate. They might not necessarily be equal in other ways, as they might differ in the number of false positive or false negative results they give, which has important implications for how the test result is interpreted. Terms like sensitivity, specificity, positive predictive value, and negative predictive value give us more information about how a test performs, and we'll come to these terms again later. To determine these values, we need a diagnostic accuracy study, and I'm going to use the example of a pregnancy test to explain this concept. Although pregnancy isn't an illness, it is a diagnosis, and it's useful for explaining the concept, because there aren't really any grey areas. Someone is either pregnant or not. You can't be a little bit pregnant. There are also simple pregnancy tests which generally give definitive answers of either positive or negative. Again, there are a few indeterminate results. So let's say we want to perform a diagnostic accuracy study on a new pregnancy test. The first thing we need is a fairly large group of women who are similar to those we will want to use the test on in our clinical practice. Generally, we would want to use the test on women of childbearing age who present to our clinic. Some will come and ask if they are pregnant, and others might not think they are pregnant, but we would want to do a test if, for example, they had unexplained abdominal pain. What we want to avoid for our study is picking a group of participants who are unlike the women in our practice, particularly if they are very unlikely to be pregnant. Once we have our group, we need to decide definitively which ones are pregnant and which are not, using some kind of reference standard, sometimes called a gold standard. In this case, we might choose to do an ultrasound of the uterus and diagnose definitive pregnancy if we see a fetus with a beating heart, as in this 12-week scan, for example. We can think of other strategies, but ultimately we need to be absolutely sure which women are pregnant and which are not. Now we can go ahead and perform our new pregnancy test, which will be either positive with 2 lines or negative with just 1 line. At this point, we will have completed our diagnostic accuracy study. To analyze the data, we need a 2x2 table like this. Women who are pregnant can either have a positive test or a negative test, and women who are not pregnant can also either have a positive test or a negative test. Tests are therefore either truly positive, truly negative, falsely positive, or falsely negative. By convention, we use the letters A, D, B, and C to represent these values. So you now know how to perform a diagnostic accuracy study when you have a test that gives definitive positive and negative results and a diagnosis that can be proven beyond reasonable doubt. But what if these conditions are not met? We will cover tests that don't have definitive positive and negative results later. For now, we will look at reference standards. We said that with pregnancy, it's fairly easy to make a diagnosis using a reference standard, but that isn't always the case. Take tuberculosis or TB, for example. This is an infection caused by Mycobacterium tuberculosis that looks like this under a microscope and looks like this when it grows in a laboratory. There is consensus among doctors that a patient definitely does have tuberculosis if a sample such as sputum, when sent to the laboratory, cultures tuberculosis. The problem comes in trying to decide which patients don't have TB, however. This is because we know that we can have a patient and send multiple specimens such as sputum to the laboratory, all of which do not grow TB, and yet the patient dies, and when an autopsy is performed, it's clear that the patient had TB throughout the body. So if we want diagnostic accuracy studies for TB, we have to get around this problem somehow. In practice, we tend to accept the imperfect reference standard and say that patients with all cultures negative don't have TB, whilst accepting that this compromises our results. In summary, diagnostic accuracy studies should be performed on a representative group of patients using an agreed reference standard to produce a 2x2 table that can be used to calculate various parameters that we will come to in our later lectures.